It's just about explaining the options and explaining everything that's involved and letting them know if they do make a decision exactly what that is going to look like. What is their life going to look like for the next few months, for the next couple of years.
That's Christopher Nelson, oncology nurse practitioner. He's joining us from Avera Medical Group Oncology and Hematology. You'll hear more from him later in the show. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Advancements in CLL research mean that patients have a wide range of treatment options to choose from. But with so many choices out there, it's important for providers to partner with patients to tailor the treatment. Today, we'll talk with two members of the cancer care team about shared decision-making. First, we'll hear from Christopher Nelson. He's here to share how he's navigated shared decision-making with his patients.
So, looking at the guidelines, when we look at first-line treatment of CLL, preferred regimens are either a BTK, and we've got a couple different ones to choose from, and then we've got a BCL2 inhibitor, and we've got one of those. So they each have their own unique attributes, and you kind of have to explain several different things to the patients when you approach shared decision-making. And shared decision-making is when you and the patient make a decision together, right? I mean, you do what the patient feels is best. You look at what their values are and what's important to them, and then you try to find a therapy that fits those. So some people, like with a BTK, they might like the idea of being on a medication for an extended amount of time. They might feel to them that you're continuing to suppress the cancer, and they might be nervous to come off of a medication. But also, you might have some patients that don't want to be on a medication. They say, oh my gosh, I'm going to be on a medication the rest of my life. And they like the idea of a fixed duration. Now, if people are on a BTK, they probably are not having to come to the clinic as much. So those are all things you have to present to the patient. The other thing that you want to review with the patient, of course, is toxicities. With BTKs, especially the second generation BTKs, the cardiovascular risk is much less than what it was with the first generation BTKs, but there are still some cardiovascular toxicities, specifically AFib and hypertension. There also is a small risk of bleeding with BTK inhibitors, so patients need to be made aware of that. Then, of course, there's risk of infection, but all patients that have CLL have an increased risk for infection. So those are things that you want to all present to the patient and then kind of talk through it and make a decision together on what best fits their preference, their lifestyle.
Christopher, how does that shared decision-making process inform treatment sequencing?
Sure. Now, we should probably talk about sequencing for a second there. So in the first line setting, we're probably going to look at doing either a BTK or a BCL2. And then at some point, the patient may relapse or may have to stop due to toxicities. Then in the second line setting, we kind of flip it. So I think, we kind of have to describe that to the patients up front and kind of let them understand what is next for them, but also let them know that there is a plan B. And that's something that I've found is really important in oncology, is telling patients that we have a plan B and we have a plan C. If something doesn't work, we always have something else that we can go to. And that is comforting to people. People like a plan. People like to know that you do have other options, that if this therapy doesn't work, then there still is more. That's not the end. When you work in oncology, make sure your patients know that you have a plan, that there is always something that you can do, and you will always search for something else. You will always try to give them something else if they do want treatment.
What about shared decision-making conversations with patients who are beyond the second-line scenarios? How do you handle those conversations?
There is a lot to consider there because there are multiple options. There's cellular therapies, like such as CAR T therapy, but those are not offered everywhere. And some patients might not like the idea of that. It's an evolved process. You have to harvest the cells, they have to be expanded, and they have to be infused back in the patient. So they might not like that idea. There is a new generation of BTK that we can use in patients that have BTK resistance genes. So again, it's kind of going back to maybe something that patients were familiar with. Maybe they were on a BTK before and they had a good experience, and maybe they feel like taking a pill is going to be a little bit easier than doing something like CAR T. So it's just about explaining the options and explaining everything that's involved and letting them know if they do make a decision, exactly what that is going to look like. What is their life going to look like for the next few months, for the next couple of years? And then, of course, presenting the data on them. You want them to understand how effective they are. And then you, of course, talk about toxicities.
What are some of the challenges when you're building that understanding with patients?
Shared decision making is one of those things. It's on a whole spectrum. There are some patients that want to be very involved in their care, and you sit down and you talk to them for a long time, and you go through everything in detail. They write stuff down. They want to think about it. They want to come back and have another appointment, and then maybe mull it over. And if they have questions, talk about it at that next appointment, and then make a decision. However, there's people on the other end of the spectrum, and they say, "Well, I don't know. You're the doc. You do what's best." So like with anything, you kind of have to assess the situation and kind of get a feel for the situation and what the patient is looking for and how involved in decision making they want to be.
What's the best approach to communicating with patients here?
Well, again, it comes down to building trust, but also, we're throwing a lot of information at them, and a lot of it might be foreign to them. So usually start slow, don't dive in real deep, repeat yourself often, and, kind of make sure that they're understanding, ask them some questions to make sure that they understand what it is you're talking about and that you're both on the same page. And again, it kind of depends on the person. Everybody's personality is different. And I think all of us that work in healthcare know how to approach people differently based on that person's personality. So you kind of have to figure out what their style is and how you should approach them.
We've talked about how these therapies can vary widely in both time frame and administration, and there's so many different treatment options out there. How do providers who are working in community oncology settings discuss these sorts of complex treatment options, including clinical trials, with their patients?
Sure. Oncology is changing, and I've been in oncology for about 15 years now and seen so much change. And it is tough to keep up on everything. So, education for the healthcare provider is important. We never stop learning. I think I'm studying, reading, and doing more now than when I was in school. But the guidelines, the NCCN guidelines are very important. And, anytime that you have a question, you can always reference the guidelines. The treatment algorithms are laid out very nicely. There's plenty of references if you want to go in there and take a deeper dive on things. And then, the second half of the NCCN guidelines is all narrative, where you can just go through and read kind of like a textbook. So I think that's an excellent educational resource for providers that's non-biased, put together by experts, and it's the consensus in the oncology community.
Here with more on discussing clinical trials with patients is Meghan McGrath from the Leukemia and Lymphoma Society.
I think it's really important to try and make every patient aware of the fact that a clinical trial could be right for them at any stage in the game, right? We know that we've only come this far because of the data that's been, obtained from clinical trials to guide us, right? I mean, you think 10 years ago, a lot of newly diagnosed patients were still getting treated with traditional cytotoxic chemotherapy. And the way that we have made such leaps and bounds is through clinical trial enrollment, getting that data and bringing it back to patients in the clinic. So helping patients understand that even if it's not available at your center, but that a newly diagnosed patient could be eligible for a clinical trial. A watch and wait patient could be eligible for a clinical trial, right? There's trials out there studying, could we treat people earlier to potentially find a cure? And there's a lot of misconceptions out there. So I think trying to normalize clinical trials and letting patients know that that is an option for them. Maybe they'll have to seek another opinion somewhere else, but it's not just what we have standard of care. And that's how we're going to move the needle forward, by getting more patients enrolled on trials.
What are some of the concerns you see among patients about clinical trials, and then how do you address those?
Yeah, so things like the fact that a trial, sometimes people think it's our last resort, right? Sometimes people might think that they're getting a placebo. Usually those are the types of things you can provide some education around. But some of the other concerns that have come up in the patients I've worked with are maybe if they're going to a center far away, that driving time is more intensive, or maybe if they're going to be getting a drug that causes a significant side effect, right, like cytokine release, and they need to be hospitalized or they need to stay overnight to be monitored, how are they going to pay for that hotel room? And a lot of people will call and say, well, I want to be on a clinical trial because I've heard that they pay for everything and then I won't get any bills. And so I think it's important to address those logistics. Sometimes trials will provide housing stipend. Sometimes they'll provide travel stipend for that, even gas mileage, that if there's a long distance from the center. So you want to make sure to ask about that. Usually there's a research nurse or a research coordinator. So the very first step is expressing interest, and then you can get more of those details that aren't public knowledge once you get a little bit deeper into the trial. If you're referring from a center that doesn't have your own trials, and you think that maybe a patient has too many barriers that you wouldn't even want to pose a trial because what if they can't get there? What if it's not financially feasible? Just know that there are resources, right? And also, we have several funds at LLS that help with copay assistance for those standard of care costs that are associated with a trial. And just for patients and providers, if this is not common knowledge, trials are not completely covered financially by the trial. A lot of times, maybe one drug or maybe just the drugs of the trial will be covered, but maybe that time in the infusion chair with your nurse is still paid for out of pocket. The labs you're getting are still billed to your insurance. The doctor's visits or the PET scan are billed to your insurance, because anything that's considered what would be part of routine care often can still get billed back to your insurance. So making sure that your insurance is within network at the center that has the clinical trial is crucial, right? Because you don't want to have those huge hospital bills be out of network. Sometimes we can work with that, and that's something else that our service does, is to help kind of individually work with patients to overcome those barriers to trial enrollment.
What would you say to a patient who might be hesitant about exploring a trial?
I think automatically you have to assume that those red flags are going to go up, and you have to be prepared to really combat those myths that trials are a last resort. Trials are studying drugs that haven't been tested in humans. Trials could contain a placebo, and maybe I'll be put on drugs that don't work at all, right? And I would say that it can take a lot of your clinic time. If you think that a patient is a really good fit for a trial at your institution, to be prepared going into that visit to address some of those concerns, right? And say, this is the standard of care. And look here, this trial has one of the standard of care drugs combined with a drug that we know is safe, but we're trying to see if we can get even better efficacy than what the standard of care offers, right? Or this trial is going to have more monitoring after treatment with blood work that's going to tell us at a deep level if your cancer is in remission. Whereas if I just give you standard of care, maybe that extra blood work and monitoring is not part of our routine care. And so just being prepared if you're going to present someone with a trial option specifically to answer those questions, but just making sure that you can provide some context. And we have a great book. It's LLS booklet on understanding clinical trials and blood cancers. It's not just specific to CLL, but I think it does a great job of kind of giving an overview that trials are really, really strictly regulated for patient safety, and gives a little bit more context to some of those concerns that people might have. And those are free booklets. You can stock those in your clinic if you are a center that has clinical trials, to kind of provide that to people when they're newly diagnosed. And so it's just another way to kind of put that bug in their ear early on.
What about providers? What support do you offer to them?
Yeah, so providers actually have the opportunity to fill out the referral to the Clinical Trial Support Center at LLS themselves. And I have worked directly with several providers. Maybe there's no ongoing clinical trials at their institution, and they have a patient who's gone through BTK inhibitors, BCL2 inhibitors, and maybe the non-covalent BTK inhibitors, and maybe they're interested in CAR T, but they want to see what else is out there, and you just don't know, right? I mean, I used to be in the clinic And you can go on clinicaltrials.gov and you can try and look around a little bit, but you can also just refer them to us, right? That's what we do day in, day out. We'll give your patient a list of potential options. We rank them by distance. We actually talk to the primary investigators, the research nurses, and we do a lot of that coordinating with the other center. And so if you have a patient, whether it's watch and wait, newly diagnosed, relapse refractory, and you think they could be a good candidate for a clinical trial, you don't have any other options to give them, they're really anxious to get started on treatment even though they're not indicated for it, that's the perfect opportunity for you to either have them reach out to us directly or for you as a provider to actually submit the referral to us. And I think sometimes it's more helpful coming from a provider because everything I get from a patient is word of mouth, right? We don't access medical records and we're not here to give medical advice. And so if I get a referral from a provider, then I'm more likely to get that recent biopsy result, that recent next generation sequencing test, to understand a little bit more specifically that the patient meets certain eligibility criteria. And that way the trial is more individualized to that patient because I have more medical information. If a patient does it themselves, we still can get very close based on what they're telling us, but from a provider referral standpoint, it's just much more specific.
We want to thank our guests today. You can click on the links in the show notes for resources on empowering patients to make informed care choices. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.